Hello, I'm Josh Weis, and I will be presenting our abstract defining benchmarks for fellowship training in foregut surgery at 10-year review of Fellowship Council index cases. Foregut disease has become increasingly complex and usually requires a multidisciplinary approach using medication, endoscopic therapies, and sometimes surgery. Foregut surgeons agree that operative technique is a key component of patient outcomes. They also agree that many scenarios involve advanced expertise to ensure the best patient outcomes, such as choosing the correct funduplication for patients with various pathologies, or deciding whether or not to place mesh around the hiatus of a difficult hiatal hernia. Additionally, foregut surgeons need to be familiar with advanced diagnostic modalities such as high-resolution esophageal manometry and esophageal pH monitoring, which are not routinely encountered in other areas of general surgery practice. Finally, new medical devices are constantly being approved for use in foregut pathology, and the modern foregut surgeon needs to be familiar with the correct indications for their use to ensure proper patient selection. Unfortunately, general surgery residents receive little exposure to complex foregut surgery during their training. In fact, according to the 2019 ACGME case log report, graduating chief residents logged a median of 10 anti-reflux procedures during their training, a median of 1 hiatal hernia repair, and a median of 0 esophageal myotomies. Beyond general surgery residency, there are currently no dedicated pathways for fellowship training in foregut surgery. The Fellowship Council is a major accrediting organization that oversees fellowships which do commonly provide exposure to foregut cases, and alumni of FC programs commonly perform foregut cases as part of their practices. Based on limited historic data, the Fellowship Council, in conjunction with sponsoring societies such as SAGES, the SSAT, and ASMBS, launched a pilot program to evaluate foregut experience of fellows enrolled in high-volume fellowships. The aim of our study was to perform a comprehensive analysis of Fellowship Council case logs and develop data-driven benchmarks for defining appropriate foregut fellowship accreditation criteria. For our analysis, we queried the FC case log database for the past 10 academic years of data from 2010 to 2019. We developed a consensus definition of complex foregut cases. This included cases involving the esophagus, stomach, duodenum, and diaphragm. Cases were excluded if they were primarily bariatric in nature, such as Roux-en-Y gastric bypass, sleeve gastrectomy, or duodenal switch. We also excluded Whipple procedures, as these were felt to be more surgical oncology and HPB procedures than foregut procedures. We also excluded gastrostomy tubes, diagnostic laparoscopies, and intraoperative ultrasounds of foregut organs, as these procedures were felt to be too simple to meet the definition of a complex foregut case. Once our case categories were defined, we stratified them into 5 index categories. These included the repair of hiatal or giant paraesophageal hernias, fundoplications, esophageal myotomies, major organ resections with anastomoses such as esophagectomies or gastrectomies, and minor organ resections such as gastric wedge resections or diverticulectomies. Finally, we decided to exclude fellowship types that did not provide fellows with an average of at least 50 foregut cases per year in the most recent year of data analyzed. Based on this threshold of 50 cases per year, we included advanced GI-MIS bariatric, advanced GI-MIS, and advanced GI fellowships in our analysis, as fellows averaged 60 to 65 foregut cases per year in these fellowships in 2019. Likewise, we excluded bariatric, thoracic, HPB, and colorectal fellowships from our analysis, as in the 2019 academic year, their fellows failed to average 50 foregut cases per fellow that year. Overall, our entire decade of analyses included 1,362 fellows who logged 82,889 operations and almost 112,000 endoscopies. We first examined the median volume of foregut cases performed by fellows each year within each index case category, looking for patterns of growth or decay. For hiatal and paraesophageal hernia repairs, we saw statistically significant growth from a median of 14 repairs in 2010 up to over 30 repairs for fellows graduating in 2019. However, the volume of fundoplications remained constant with no significant change over the 10 years analyzed, with median volumes hovering in the mid to high teens. For the categories of esophageal myotomy, major organ resection, and minor organ resection, there were no significant changes over the decade analyzed, and the volumes were overall quite low, with median experience in the low single digits. The total foregut cases per fellow did grow significantly over the decade analyzed, from a median of 42 complex foregut cases per fellow in 2010 to almost 70 foregut cases per fellow for those graduating in 2019, with this growth driven largely by the increase in hiatal and paraesophageal hernia repairs. Regarding endoscopy, volumes did increase significantly over time for diagnostic, therapeutic, and total endoscopies. However, it's important to note that therapeutic endoscopy remains relatively uncommon in these fellowships, with the median growing from only 1 therapeutic endoscopy in 2010 up to only 4 in 2019. We also wanted to look at the approach being used by fellows to complete complex foregut cases. Interestingly, over the decade analyzed, we saw the share of cases being done laparoscopically decrease from around 91% in 2010 to around 80% in 2019. During the same time period, the share of cases done through an open approach decreased from around 9% to around 3%, whereas robotic cases grew from less than 1% to almost 16%. In summary, FC Fellows in Advanced GI, Advanced GI MIS, and Advanced GI MIS Bariatric Fellowships routinely perform high volumes of complex foregut cases and diagnostic endoscopies. These complex foregut cases are predominantly hiatal paraesophageal hernia repairs or fundoplications, with a small volume of organ resections and myotomies. Also, although robotic foregut surgery is growing, the overwhelming majority of cases are still performed laparoscopically in FC fellowships by almost a 5-to-1 ratio. Our study has several limitations. First, our data do not include Roux-en-Y gastric bypass cases that were performed for foregut indications such as GERD or paraesophageal hernia repair, as the case log system does not have sufficient granularity to tease out this data. Second, POEM procedures were counted as therapeutic endoscopies in our analysis, not esophageal myotomies. Finally, the size and complexity of hiatal hernia repairs is unknown, again related to case log limitations. We predict that these data will be useful in developing criteria for foregut fellowships and/or focused practice designations as the ABS expands this program. Thank you for watching. I hope you enjoyed the presentation.